I am Dr. George Ampat and work as a consultant orthopedic surgeon in Liverpool in United Kingdom. I also work as a clinical teacher in the School of Medicine, University of Liverpool. What I'm going to present to you is part of the research work that we have done for Atrix Incorporation. Though the study was funded and sponsored by Atrix, they were not involved with any part of the study, including the design, the documentation of the results, or the publication of the study findings. The research was conducted completely independent of the sponsors. Foot pain is quite common among older adults. Nearly 24% of older adults, or 1 in 4 older adults, experience frequent foot pain. Foot pain can not only cause physical disability, but can also lead to psychological difficulties. Depressive symptoms were twice as common in older patients with foot pain. In addition, there is an increased incidence of falls in older adults. Older adults who fall frequently seem to have an increased prevalence of foot pain as compared to other older adults who do not have falls. Falls can result in serious injuries in older adults. A common serious injury is a fracture of the hip. 95% of hip fractures in older adults are caused by falls, and unfortunately, 25% of patients with hip fractures will die within the first year. Falls not only cause pain and disability to the person who has fallen, it costs a lot of money both to the individual and the state. The cost of falls in the United States is $50 billion. Similarly, the cost of falls in the United Kingdom is £2 billion. In summary, older adults have an increased prevalence of foot pain. The increased prevalence of foot pain decreases mobility. The decreased mobility increases frailty or weakness. The increased frailty increases the chance of falls. The falls may result in serious injuries like hip fractures. Hence, the priorities in the older adults are to decrease foot pain, decrease generalized musculoskeletal pain, improve mobility, decrease frailty, improve balance, and decrease falls. This would then enable the older adult to age healthily. What we know is that orthotics can decrease pain and also improve balance. It decreases pain by increasing the surface area of contact between the foot and the orthotic. In a normal footwear, the contact between the under part of the foot and the upper part of the sole of the footwear is limited, the main contact being at the heel and the ball of the foot. However, when using contoured prefabricated orthotics, the area of contact between the undersurface of the foot and the orthotic increases. The increased surface area decreases the pressure, and thereby there is reduction of pain experienced in the foot. Increasing the surface area also increases the sensory input from the foot to the brain. Since a wider area of the skin is in contact, there are more nerve endings involved in conveying the message to the brain. This allows the brain to sense body position and body awareness better. Through the University of Liverpool, we conducted a randomized controlled trial to investigate whether the Atrix prefabricated orthotics with and without metatarsal pad would decrease pain and fear of falling in older adults. We used the premium memory foam orthotic, the L2300 and the L2305. Previous studies had either investigated orthotics without metatarsal pad or with metatarsal pad. There has never been a study which directly compared orthotics with and without the metatarsal pad. Our study was unique and first of its kind, which directly compared an orthotic with metatarsal pad against an orthotic without a metatarsal pad. Requisite approval was obtained from the NHS Rec Committee and the trial was registered with clinicaltrials.gov, a US-based database. A power analysis was done prior to the commencement of the study to determine the numbers required. Subsequently, 206 participants who had volunteered were randomized into either the study group and provided with an orthotic with metatarsal pad, or into the control group and provided with an orthotic without a metatarsal pad. Patients were randomized by opening opaque sealed envelopes that allowed them or allotted them to one of the groups. At baseline, demographic data, numerical rating scores of pain in the lower back, hips, knees and ankle and feet, foot health status questionnaire of both the pain and function subscales, and fear of falling data were collected. Following randomization and inclusion into the study, patients were asked to wear the provided orthotics whenever possible for the following 6 weeks. At 6 weeks, the same outcome measures were again collected to determine any difference from baseline scores. Numerical rating scales are scores provided by participants on a scale of 0 to 10, where 0 is no pain and 10 is the worst possible pain. Overall, results of both the groups were as follows. Back pain decreased by 27.4%, hip pain decreased by 29.6%, knee pain decreased by 20.4%, ankle pain decreased by 28.6%, and foot pain decreased by 36.43%. All the changes were statistically significant. Pain and function of the foot was also measured using the foot health status questionnaire, which instead of giving a number provides statements, and participants had to choose a statement that best described their current status of pain or function. Foot pain by the FSHQ subscale decreased by 39.5%, and foot function on the FSHQ subscale improved by 34.6%. Fear of falling, as measured by the Falls Efficacy Scale International, decreased by 10.7%. There was a statistically significant improvement in both groups. The improvement was greater in the group with the metatarsal pad, but the difference did not reach statistical significance. It seems that the metatarsal pad placed underneath the ball of the foot decreases fear of falling to a greater extent than just the standard orthotic, though this was not statistically significant. This advantage of the metatarsal pad can be explained because of the selectively greater number of nerve endings in the ball of the foot. In day-to-day activities, if we have to gauge the evenness of the flow, we use the ball of the foot rather than any other part of the foot. This is a practical demonstration that the increased nerve endings found in the ball of the foot. Both the standard orthotic and the orthotic with the metatarsal pad decrease fear of falling, but the orthotic with the metatarsal pad seemed to be better. We only measured fear of falling and not actually the falls. It is possible that the metatarsal pad provides an easily discernible point of reference for the foot. It seems to function like a white stick that is used by the visually impaired. The white stick provides tactile feedback to the visually impaired. Similarly, the orthotic with the metatarsal pad has a prominent projection underneath the ball of the foot, which provides a greater reference to sense body position and body awareness. In summary and to recap, both the orthotic with the metatarsal pad and without the metatarsal pad decrease back pain in older adults. Both the orthotic with the metatarsal pad and without the metatarsal pad decreased hip pain in older adults. Both the orthotic with the metatarsal pad and without the metatarsal pad decrease knee pain in older adults. Both the orthotic with the metatarsal pad and without the metatarsal pad decrease ankle pain in older adults. Both the orthotic with the metatarsal pad and without the metatarsal pad decrease foot pain in older adults. Both these orthotics also increase foot function in older adults. Both the orthotic with the metatarsal pad and without the metatarsal pad decrease fear of falling in older adults. There was greater benefit with the metatarsal pad. Let us go through the life cycle of a human. We are born as infants, progress to becoming toddlers, little children, teenagers, and then as adults start useful employment between 20 and 30. We hopefully work until 60 to 70 when slowly our aches and pains commence. We then pass away in our late 80s and 90s. It seems that the last 20 to 30 years towards the end of life is riddled with aches and pains. If we are disabled in our later years, then that does not represent healthy aging. It is thus important to reduce the period of disability in our later years by keeping as active as possible. The prefabricated orthotics presents one such option to improve activity levels and to remain healthy. Prefabricated orthotics are not the only solution, but one of the components that can be used to promote healthy aging. We are extremely honored that we had an opportunity to do this research during the UN Decade of Healthy Aging. We have presented this work in the EFAT Congress in Vienna in 2023 and have also published it in Physical and Occupational Therapy in Geriatrics. You can also access the publication with the following link. Thank you so much for listening. Goodbye.